These days it's popular to talk about spectrum disorders, of bipolar spectrum disorders. Bipolar 1, of course, is classic manic depressive illness. And as I mentioned in our last class, one thing that's been found is that probably 2/3 of people who have bipolar don't, in fact, get back to places where they're entirely normal functioning in between episodes. It used to be thought that you had the bad episodes and then people are really totally normal, but lots of them are not. But this is severe manic depressive illness. Nothing really different here in terms of diagnosis. Lifetime prevalence rate 1%. Okay, and excuse me. There was one other point I failed to mention, and that is that let's just rewind for a moment. People have a lot of these other mental illnesses. They're troubled people. They have problems, and then they find people and they develop relationships and get married and stuff like that. So in a sense, you kind of know who you're marrying. But like with this physician, for instance, he showed no signs of any kind of severe mental illness, and all of a sudden, it hits him, and it's a nightmare. But it's also a nightmare for his family. Yeah.
How old was he when that happened?
32. Yeah. Now we'll see that you can have early onset bipolar, but you can have bipolar. It's rare that you get bipolar disorder first episode after the age of 35, but you clearly get it. You can get it in your 30s. Okay. Anyway. Okay. And then bipolar 2 with hypomanias. Now this is the biggest problem because this is where it gets misdiagnosed a lot. People don't come in, to get treatment for hypomanias. They feel great. No one would come in and say, "Please help me. I'm feeling too good." They come in for depressions, and oftentimes the hypomanias may be very hard to diagnose, even in getting a good history. Now, if you go on online, did I mention about the website for the DSM-5? Did I mention that last time? Okay. You will see that they're still arguing. They have these task forces that deal with each class of disorders. They're still trying to carve out what's going to happen in DSM-5. This is probably what's going to change. Is in DSM-4, to meet criteria for bipolar 2, you had to have at least one major depressive episode, at least one hypomanic episode. Hypomania needed to last at least 4 days. And probably 5 years ago, they did some more up-to-date epidemiological studies showing that, in fact, the most common hypomanic episode lasts about 2 or 3 days. Okay, so basically, it was wrong to establish criterion where it says 4 days. So they're probably going to do this. They're going to reduce it that you have to have a history of a hypomanic episode that lasts at 2 days or more. Now, with this revised criteria for this diagnosis, then that is what accounts for it at being seen at a much higher prevalence rate than they once thought, 4% of the population. And it's looking more and more like a lot of people that present clinically as having recurrent or chronic depressions, especially treatment-resistant depressions, may in fact have bipolar 2. And that it just never gets diagnosed or doesn't get diagnosed for a long period of time. They don't have manias, thank God, but they have lots and lots of depressions. Okay. Now, in your handout in the material that with your quick reference, if you look in there, there's something called a mood disorder questionnaire. This is a separate handout. I'll take a minute to find that. It's in the one that has all the other rating scales and that sort of thing. It's after the STAR-D stuff. There it is, Mood Disorder Questionnaire. Okay. And by the way, I think I mentioned this last time, but all these questionnaires are public domain, so you can make copies and you're not going to get in trouble for copyright infringement. Okay, now the Mood Disorder Questionnaire is widely used now, and every single person who presents with depression should be given a Mood Disorder Questionnaire. It takes 5 minutes to fill out. It's high yield. It's quite sensitive and specific for picking up a history of mania or hypomania. And when they did the research on this, they said that to be very clear that there's bipolar disorder going on, you have to endorse 7 or more of these items. But the truth is, even if the person endorses a couple of the items, then that is absolutely a reason for questioning them. We talked last time, I think, about the importance of meeting with family members. They are the ones who are in the best position to really give information, especially about history of hypomanias, but this is a good screening instrument, okay? And I don't remember if I said this last time or not, but I'll just say it again. And that is, somebody comes in and they're depressed and say, why are you depressed? Well, I'm going through a divorce. Or they're foreclosing on my house. Or, they talk about some kind of really significant life event, which is a precipitator for the depression. But that tells you nothing about whether it's a unipolar depression or bipolar, because people who have bipolar disorder are just as likely as anybody else to have life stresses provoke episodes. In the classic literature, they say this is an endogenous mood disorder, that you have spontaneous depressions and manias, even in the absence of psychological stressors. That can be the case, especially after a few episodes. Then people can start having what really are spontaneous episodes in the absence of psychological stressors. But early on, in fact, probably in 2/3 of cases, the first one or two depressions are clearly ushered in by exposure to significant life stresses. So, having a stressor provoke a depression says nothing about whether it's unipolar or bipolar. So for this reason, every person who is depressed really, as a part of routine, initial evaluation should be given the mood disorder questionnaire. Okay.
Dr. Nelson, I have a question.
Yeah.
I'm just wondering if you have any advice on trying to do this screening for mania and hypomania for clients with substance abuse issues, because I have a ton of clients who I've had referred and have diagnosis of bipolar, but they have a history of meth use and things like that, and it's really hard to
Okay, this is a great question.
And I don't know what the best way to go about this.
Okay, well, I don't know if everybody heard that or not, but it's making a differential diagnosis between history of mania and drug abuse, especially cocaine or methamphetamine. And first off, it's oftentimes hard. Keep in mind, dogs can have fleas and ticks. There are bipolar people that also abuse drugs, so you can have comorbidity as well. But it's clearly an issue, okay? Now, here's the deal, and that is if you have periods of time that you have what looks like manic behavior, it's substance-induced mania. In fact, I'm going to be talking about that a little bit later on. Number one is if you do drug screen, obviously you're going to pick it up, okay? Secondly, if they stop using the drug, almost always it will resolve within 1 to 2 weeks. Where with most manic episodes, once it gets started, if you don't treat it, it'll last on average 3 months. Okay, but the problem is that people that are being seen on an outpatient basis, we don't oftentimes get drug screens. They continue to abuse substances, so it becomes very difficult. Now, the main thing that's different is that when you have substance-induced mania, if it's a full-blown spectrum of manic symptoms, grandiosity, pressured speech, decreased need for sleep, hyperactivity, or it could be dysphoric mania. If it meets all the criteria for mania, most of the time that person is bipolar, but the bipolar has been ignited by the substance abuse, and that's something you can evaluate, clinically in the here and now. Okay, most people that, however, that have a history of stimulant abuse, that's where it gets difficult because it's hard to evaluate, do they meet full spectrum diagnosis for mania. Okay, so it's just very, very hard. It's very hard. Okay, and if you suspect that substance abuse is a part of this, then I think it's not appropriate to say bipolar disorder. I say rule out bipolar disorder, but substance abuse is clearly a possibility. And I think I may have mentioned this last time, this is the group of people that have the highest rates of substance abuse of all psychiatric patients. The most common are alcohol and marijuana abuse, but also you can have people that are into stimulant abuse. Okay. Okay, bipolar 3. Now, if you look at the history of this disorder in the literature, it has these little smaller notations here: pseudo-unipolar depression, highly recurrent major depression. These are terms that have been used over maybe the last 20 years. And here's part of the argument, and that is, right now, if you use DSM-4, and somebody they're having their second major depression, and it's unipolar, okay, then the diagnosis is major depression, unipolar, recurrent. If you have a person that's having their 20th episode, there's been no mania, they're having their 20th episode, they have the exact same diagnosis. Major depression, unipolar, recurrent. And the argument is, wait a minute, are these the same folks? And the evidence is suggesting no, they're not, okay? Now, this may or may not make it into DSM-5. It's unclear. But the people that are kind of, cutting-edge researchers in bipolar are saying this is a distinct condition separate from recurrent unipolar depression. 20% of people, as we talked about in our last class, that have major depression will go on to have additional episodes. But a lot of these people are going to have 3 or 4 or 5 episodes, not 20 or 30 episodes. So what bipolar 3 is then, it is, and I'll spend some time really talking about this, it's a person who has a lot of depressions, okay, a multitude of severe depressions, but they are characterized in ways that make them look somewhat different than regular unipolar depression. Okay, the first thing is that they tend to not last as long. If you look at the natural history of unipolar major depression, most people that develop a depression and get no treatment, it will last for 9 to 12 months, give or take a couple of months, and then spontaneous remission. Now, obviously, there are exceptions to this, but long before they had any treatments for depression, it was very clear that, they didn't do anything. People just had to ride out the storm. And most unipolar depressions would last 9 to 12 months, again, give or take a few months, okay, and then people will come out of this. Now, these depressions, however, are much more brief. They tend to be 8 weeks, maybe 12 weeks, and then people spontaneously come out of them. So one thing that is very different is the duration of the episodes is much more brief. But please understand that when people get depressed, that the severity of depression is equally severe to any other kind of major depression. And we're talking about full-blown depressions. It just doesn't last as long, okay? But why do you call this bipolar? If there's no mania, there's no hypomania, and there isn't typically. Okay, well, number one is if you take family history, there tends to be a number of blood relatives that have bipolar spectrum disorders. Secondly, is that antidepressants do not work in treating bipolar depression, and these people tend to, when they've been treated with antidepressants, not respond. The worst part of it, though, is that if they're given antidepressants, it can provoke a switch into mania. And so it's not uncommon, and I've seen people like this, gosh, nobody knew about this stuff 20 years ago or even 10 years ago, but I've seen people that had 15 episodes of depression, and there was no mania, and so everybody said, well, just highly recurrent unipolar depression. But if you give these people antidepressants, usually it just doesn't work. But sometimes it can provoke a switch into mania, and once they have their first manic episode, it's like letting the cows out of the barn. You can't get it back in. Beyond that point, they'll start having spontaneous manic episodes. So this is a nightmare to begin with. But if they're inappropriately treated with antidepressants and it blows the lid off of this and you start having manias, now it's gone from really bad to worse. Okay. Actually, let me go back here for just a minute. How you diagnose this are, one, it is multiple episodes, short duration. Okay. Number two, family history, where you have a lot of bipolarity in blood relatives. The third thing is that typically the first depression has occurred either in childhood or early adolescence. So it's an early onset mood disorder.
Are there any, antidepressants that induce mania more often than others?
Yes, let me ask that question in just a moment because I don't want to forget this last point. Okay. History of lack of response to antidepressants. Okay, so let me go over those again. Okay, history of many depressions that are severe but brief, okay? Family history, blood relatives with bipolar disorder, okay? Early onset, first episode, and history of failure to respond to antidepressants. Now, getting back to your question, yeah, tricyclic antidepressants are 2 to 3 times more likely to cause mania than the newer generation antidepressants. But please be clear, the newer antidepressants can cause mania. What if you get somebody like this? No history of mania, no history of hypomania, but they've got all those other characteristics. Okay, the first rule of medicine is do no harm. And so what I think I would do is I'd have a sit-down talk with the patient and, if possible, their significant other, and I would say, it appears like you may have what's called bipolar 3. And I would just tell them the story. I would say, here are the risks. There are clearly risks in using antidepressant medications. And so the safest course of action would be to use drugs that treat bipolar depression. And we'll talk about specifically what those are here in just a few minutes. The downside is the drugs that are used to treat bipolar depression, with a couple of exceptions, have a less benign side effect profile. Bipolar drugs, with a couple of exceptions, just have more side effects. So the person may be subjected to side effects, but think about the possibility of unleashing manic episodes into this person's life if they're given an antidepressant. I think the risks are too great